Hello, my name is Marcel Robles. I'm an intern at Santa Elizabeth Medical Center, and today I have the pleasure of presenting a case I submitted to ACP. Without further ado, I present segmental colitis associated diverticulosis, masquerading as partially obstructive rectal sigmoid mass with bowel perforation. I have no disclosures. What is the segmental colitis associated diverticulosis? It is also known as SCAD, and it is a rare form of diverticular disease characterized by an active inflammation at the level of colonic area presenting diverticulosis. With that in mind, I present a case of a 44-year-old gentleman with a history of 4 days of constipation and rectal pressure. He endorsed bloating with increased straining during bowel movements with minimal amounts of stool. He has a history of recent travel, weight loss, nausea, vomiting, abdominal pain, or presence of blood or mucus in his stool. In regards to past medical history, surgical history, and family history, and social history, it was non-contributory. In regards to physical exam, it was only noteworthy for morbid obesity upon inspection. In regards to his initial evaluation, in the CBC it was noted that he had normocytic anemia. He had a normal chemical panel, normal chest x-ray, and a non-contrast CT abdomen pelvis was ordered. In it, we see a probable rectal sigmoid colon mass without obstruction, but with adjacent metastatic lymphadenopathy or peritoneal implants measuring up to 4 times 3.5 centimeters. At this time in the hospital course, a presumptive diagnosis of colorectal mass was made. The GI, surgery, and oncology departments were following the case, and oncology recommended ordering a CT chest, abdomen, and pelvis with contrast for clinical staging. In it, we see a rectal sigmoid mass, which is partially obstructing, with evidence of tumor perforation with some fluid or tumor masses surrounding the rectum in the perirectal space. At this point in the workup, a presumptive diagnosis of partially obstructed colorectal mass with contained perforation was made. The patient was started prophylactic antibiotic therapy. Of note, the patient remained hemodynamically stable with a normal abdominal exam throughout his examination. Despite concerns of bowel obstruction, given the patient's clinical stability, a non-invasive approach was taken more into consideration instead of an invasive approach, and as a result, a diagnostic flexible sigmoidoscopy with biopsy was ordered. In it, an area of significant congested and erythematous mucosa was found in the rectal sigmoid colon and in the distal sigmoid colon. A single diverticulum was noted in this area as well. Biopsy of the normal mucosa was taken and no evidence of malignancy or mass were found. In the pathology report, sigmoid inflammation with colonic mucosa with iron deposits within the lamina propria consistent with prior hemorrhage or congestion was found, with no evidence of malignancy. So, what are the classic presentations of SCAD? The classic presentation includes a self-limited hematochezia and cramping abdominal pain. The first being present in 70% of the cases. It's typically found in male over 50 years and is often misdiagnosed with inflammatory bowel disease or occult malignancy. The diagnosis is based on endoscopic findings, which include the presence of inflammation detected within interdiverticular orifices. What is the progression of the disease? The course is normally benign with spontaneous resolution. However, it has been demonstrated that 5-aminosalicylates or steroids may make the recovery faster. So, what is the importance of this clinical vignette? To our knowledge, it is the first reported case of SCAD presenting in this manner. The presentation and imaging of the case triggered a workup of colorectal malignancy. The presence of perforation made an invasive approach to be considered. However, given the clinical stability of the patient, a non-invasive approach was taken. This clinical vignette provides support for a minimally invasive approach to diagnosis in the setting of bowel perforation with signs of clinical stability. These are the references. Thank you very much for your attention.